we go to the last presentation of today. So the last person who will ask some important question to Xabi and to Ercilia and Robert, which is Elisa. She's not in the room. Hi, Elisa. So nice to see you. Sorry that you could not join. Is it okay for
Hello.
you to share the screen?
Yeah, thank you. I will do so. Thank you, Rosa.
So Elisa
Yeah.
is from Madrid. She's from the regulatory agency of Spain. And she will tell us a story of a study that she conducted where she did have some validation parameters, but the methodology to incorporate them into her results were missing. So please go ahead with your story, Lisa, which is, I think, very interesting.
Thank you very much. Please let me know whether you see my screen.
Yes, yes, Elisa, we see it well.
Okay. So thank you very much. Good afternoon, everyone. I apologize for not being in Florence today. I hope you have a very lovely day together there. As Rosa said, I work in the division of pharmacoepidemiology and pharmacovigilance of the Spanish Agency of Medicine and Medical Devices, uh, where my main activity is to perform studies using the database BIFAP. I will introduce BIFAP. As many of you already know, BIFAP is a database made of electronic health records of primary healthcare setting. Currently, BIFAP has a data of 22 million patients, which is 40% of Spanish population. BIFAP is rather a common data model of data provided by 9 regions out of 17 in the country. And this year, we expect to incorporate 3 more regions in the new updated database for the current year. And BIFAP is linked to hospital discharge and diagnosis and SARS-CoV-2 test results. Data validation in BIFAP is paramount, as in any other source of data. I don't know if you. Okay, I'm listening some noise. Sorry. Okay, I mean that data validation is paramount in BIFAP as in any other source of data, secondary source of data. We are aware of the possibility of bias from outcome misclassification due to many reasons. First, the imprecise algorithms that we may be applying to identify usually incident cases and its date, and also the potential recording of presumed or suspected diagnosis by the GP, rather than including the final confirmed diagnosis with the diagnostic code. Also because we carrying out research on outcomes diagnosed in secondary healthcare while we are using a primary healthcare database, such as the case of the studies trying to identify fractures that required a comprehensive and systematic recording of the result of MRI that usually are not included in the primary care databases. In BIFAP, we measure outcome misclassification on most of the studies we perform, and we mean what we try is to basically identify true positive by manually reviewing of clinical histories, because in BIFAP there is fields for free test comment that can be filled by the GPs. And we use those as gold standard, or let's say reference standard, to look for objective information to confirm or reject that the diagnosis was, let's say, established or confirmed in the clinical setting. We then usually correct the estimates, usually odd ratio or hazard ratios, for outcome misclassification by restricting the analysis to confirmed cases On the slide, you may see an example of a piece of a clinical history, such as it is shown in the tool that we use in BIFAP to review the pseudonymized clinical information of a given patient. You may see a D for diagnosis, CM for free text comment, and other clinical data recorded by order by date. As you may see here, there are some free text comments that are usually a description of the clinical outcome that made by the GP, but also the GP may enter a copy of the hospital discharge diagnosis as well as the specialist report or the diagnostic test results. So we have been using those fields as gold standard or reference standard to look for information to confirm the cases. That is the best that we have for years. However, we acknowledge that may be time consuming and it also quite subjective within every reviewer and also between reviewers. So, for instance, in that study that I show you now on the screen, we utilize natural language processing to verify the instances automatically identified. We use those algorithm, or I mean the natural language processing algorithm, to confirm cases of multiple vertebral fracture rather than manually reviewing all the entire instances we identified with the first automatic algorithm, because in this case we have more than 3,000 cases to review. As a case study, let me show you how we assess and address a potential misclassification on the severe COVID that we wanted to study in a study aimed to assess the effectiveness of COVID vaccine against severe COVID. You may see on the screen the flowchart of that study conducted in 2021. From 7 million patients in BIFAP, we identify around 300,000 with a complete primary vaccination and selected a similar number of matched unvaccinated controls. In that moment, we didn't have the information on the primary reason for admission. So what we did is to apply an algorithm to identify hospitalization with COVID-19, SARS-CoV-2 infection, or pneumonia around a positive SARS-CoV-2 test. That algorithm would be a proxy to identify hospitalization for COVID-19. In the hospital discharge diagnosis, there is the possibility for recording up to 20 reasons for admission in a given admission. So the hospitalization with COVID could be misclassified, could be some patients that were hospitalized for other main reason and accidentally detected as positive to SARS-CoV-2. So that would lead to an underestimation or overestimation of the vaccine effectiveness if that misclassification were differential between vaccinated and controls. Thus, we identify 79 hospitalizations with COVID in the vaccinated group and double that number among controls. Our validation objective was, as I said, to assess whether COVID-19 was the main reason for those hospitalizations, and if not, to assess what the misclassification was among vaccinated and controls. The validation method was a manual review of patient clinical notes blinded to the vaccination status. Initially, we review a sample size to estimate the BP value, the positive predictive value. However, since we didn't find or we didn't have a statistical method or application to correct the hazard ratio by the PP value, we eventually we review the total number of cases to identify false positive. We didn't have many, so that was affordable. So we estimated the effectiveness before correction using the cases identified with the algorithm, with the effectiveness shown on the screen. And during the validation process, we identified that 44% of hospitalization with COVID among vaccinated were confirmed to be hospitalized for COVID, while the 69% of controls were really confirmed to be hospitalized for COVID. Thus, the outcome was misclassified, and that misclassification was differential between vaccinated and controls. Also, the missing information to confirm or reject the reason for admission was COVID seems to be differential between vaccinated and controls, suggesting that the recording or the medical assistance could also be differential between them. Then what we did to correct the effectiveness was basically to remove the hospitalization for other reasons and kept those confirmed to be hospitalized for COVID. And also we kept those with missing information to confirm or reject. That may be as a strong assumption, but we didn't, I mean, that was an option. I think also assuming them to be false is also a strong assumption. So that is one of the challenge that we found here. And we usually face that because our so-called or yes, our gold standard or reference standard include missing information to confirm or reject. So the second challenge that we face here, and that happened also to other outcomes that we usually study, I mean the rare diseases, is that is the low sample size, especially in this case when we stratified by type of vaccines that they were very few cases in some of the vaccines group. Just to mention that before and after correction, the underestimation was up to 27% for Moderna or Janssen vaccine, and was unaffected for AstraZeneca, a little for Pfizer. But as I mentioned, the PP values were quite imprecise. And the last thing that I wanted to present is how can we adjust the vaccine effectiveness? You see the PP value derived from a different study. We replicated what I have explained. Was replicated for adolescent population in BIFAP. So we did a manual review and PP value estimation of the hospitalization with COVID in people aged 12 to 18 years, and observed a similar misclassification between vaccinated and unvaccinated people. We wanted to apply those PP values to the effectiveness that we had observed for BIFAP among adolescents in the study, in the COVID study, ROC12 study, in which many of you took part as well. And we didn't know how to apply those PP values to that effectiveness, because the application that we knew, I shared the link to that application that was developed in the advanced project in which Rosa also took part, and she was involved in that in the generation of that application. That application correct risk ratio according to PP value and sensitivity, but it cannot be used to correct hazard ratio. That What we did was basically to remove the proportion of automatic cases expected to be false positive according to the PP values, and the effectiveness moved up to 75%, which was more in line with the literature, with the other databases, and also with the clinical trials. And this is my last slide. Some request for Professors Celia and Robert is that if you could inform about any statistical method for adjusting the hazard ratio by the PP values, and also maybe to provide guidance on handling imprecise PP value and frequent missing information in the available gold standard or reference standard. And for investigator Savi, I have I think many things have already been said. I would say to estimate PV value, of course, or other validation parameters that according to the aim of your study, by exposure categories to detect differential misclassification, correct the estimates accordingly to proper interpretation, even if target trial emulations are used for the study or will be used for the study, and also plan for building reusable natural language processing algorithm or any other artificial intelligence based algorithm for saving human resources be replicable in other studies. This is my last slide. Thank you very much for your attention.
Okay, perfect. Elisa, there was a huge applause. You could not hear that, but there was a huge applause.